So the discussion is around the topic of adherence to treatment, and in particular, how can adherence to treatment be improved in patients with psoriasis and psoriatic arthritis? Can you go to the next slide, please? Next. So just some insight to have a background of this issue of adherence. Adherence to treatment is crucial for successful disease management and reduction in clinical severity of the disease. However, it is estimated that nearly 40% of patients with psoriasis do not use medication as prescribed. And this is the reference for this figure. The positive association between clinical treatment success and satisfaction suggests that the use of effective drugs that provide greater reduction in disease severity may contribute to higher rates of satisfaction and consequently adherence. Next. These are a systematic literature review collecting all the study investigating the issues of adherence and the adherence rate in patients with psoriasis. And in the table, you can see that the range of adherence is ranging a lot, but is frequently, as a mean, is 40%. So the first question for discussion is, do you agree with the 40% rate of non-adherence to therapy in patients with psoriasis? I share my... Yes, I share my contribution, and then please jump into the discussion. I think that for topical treatment, the non-adherence is even higher than 40% for topical. For systemic, I would say a little bit less, but anyway, around 20–30%.
So, hi, Paolo. Good morning. I just wanted to add, Ciao. I wanted to add to the conversation. We recently had, which is why it's fresh in my mind, we had a fun debate at the recent GRAPPA meeting about, methotrexate's use, right? Where should it be in the treatment armamentarium for psoriasis, for psoriatic arthritis? In reviewing that, I was reminded about how abysmal, in fact, adherence is specifically around methotrexate. Sorry for some of the methotrexate followers. I'm one of them, especially on the PsA side. But I will say, when we think about adherence, one of the pieces I think we sometimes forget is the tolerability piece, and methotrexate in particular is pretty poorly tolerated. There's the monitoring requirements, and yet so many of us, especially in certain regions, either use it or are forced to use it first line, especially in PsA, but often in PsO. And I just think we've come such a long way with so many other oral systemic, injectable systemic, infrequent, safe, well-tolerated drugs that's one I wanted to highlight for the group, because I do think that's one of the challenges to adherence, I think, is methotrexate specifically. And I think that can also turn patients off sometimes to subsequent therapy or subsequent systemic therapy if they have a bad experience. So I just wanted to add that.
Thank you very much, Joseph, for this comment. Yes, I meant also for non-adherence, intentional non-adherence of the patient, not only in terms of tolerability, that I would like to do the drug, but I can't tolerate the drug, so I stop the drug because I don't tolerate it. But I know I should take the drug, but for any reason, I don't follow the prescription, right?
Can I say something?
Of course. Please do it.
So it's Alice from New York. I was wondering, in your literature review, if you looked at drugs that were, let's say for psoriasis, I'm not talking about psoriatic arthritis, but for psoriasis, if you're looking at drugs that work quickly, have high rates of clearance, and that people don't have to worry about being able to pay for them, do you really think the adherence is so poor? I would argue from my practice it's not. That if you have drugs that really work well, work quickly, and they can afford it, people do stay on their treatment because they know what happens when they don't. And I don't know whether your literature, I mean, it's not surprising to me that people don't want to smear themselves with greasy stuff that doesn't work that well. I mean, would you do it? I wouldn't. Anyway, and pills that make you sick or have terrible side effects, or biologics that don't work that well either. There's some that don't work that well. So has your literature review broken it down by efficacy of treatment, affordability, and completeness of treatment? Because I think this general statement is unfair to patients. But it's not true that 40% of my patients are not adherent to treatment.
Yes, thank you, Alice. It was a collection of all the study investigating this topic. So topical treatment were combined with systemics, were combined also with biologics. So I think that your comment is very right in a way that we should distinguish non-adherence to topicals, non-adherence to systemics that could be affected by tolerability issues and not working very well, and versus biologics, high effective biologic and very, very well tolerated. What do you think about it?
That's what I was asking, whether your literature review broke it down by treatment class.
No, not by treatment class. It was an overall assessment, a generalization.
So I think that's not fair to patients, to be honest.
Yeah.
That's putting the blame on them, and it's not really, first of all, I don't think it's accurate. It's dependent on class, and second of all, it's blaming the victim, not the treatment.
Yeah, the issues of treatment to be affordable in Italy, for instance, the patient don't pay for the biologics, nothing.
Yes. Well, I think that, again, this survey, who surveyed this, I mean, in the United States, many times I take care of poor patients. When they get covered, they get covered. But for people who are not covered by the government,
yeah,
affordability is an issue, and I don't think the U.S. is the only country where that's the case. So again, I think the general applicability of this statement that's posted there, I think, is quite limited.
Yeah,
it has a lot of limitations.
Yeah,
and if I were a patient, I'd be upset. I mean,
what do other things? I don't know, Laura, Uli.
So I would agree to this statement, but there is probably a limitation regarding the region and the healthcare system you're working in.
Yeah.
For example, in Germany, these numbers seem to be very accurate, and one reason for this is that the patient will have a package leaflet in the drug they get from the pharmacy. And unfortunately, the time that dermatologists can spend to explain to the patient a little bit about the mechanism of action and how they should best use the topical treatment is then flanked by the information in the package leaflet about all the possible adverse events. And we have done surveys in Germany, mainly by Matthias Augustin, about that people get their prescription from the doctor, and even before they go to the pharmacy, some of them are not using the prescription to get the drug. So that's a first level of non-adherent behavior. And then the second step is they get the drug from the pharmacy, they're coming home reading the package leaflet, and they immediately drop what they just got for free from the pharmacy to the waste basket. And that's the next step of non-adherent behavior. And then there is a very important one. If people do not discover that there is an improvement of their skin condition within 3 days of using a topical, they stop using it. So this is a very complex scenario we are in, and therefore I think a general statement is difficult to do. But in some, at least some systems, it is the rate like that.
Thank you very much, Uli. André?
Yeah, I completely agree with almost everyone. And I think it's too heterogeneous a subject to put into just one statement.
Okay.
There's the question of access. There's the question if it is systemic or topical therapy. Topical therapy has much lower adherence than systemic therapy. Systemic therapy here in Brazil, biologics are given through the government or through the private healthcare system. And our impression, what we think about is, because we don't have the data, but is that people on the private healthcare system, they do much better because they need to go to a clinic to get their biologics applied. In the public healthcare system, the government gives the medication and they do as they please. As Ulrich was saying, and they get the leaflet, but they do not follow the leaflet. They do not adhere to the dosing and to the spacing of the dosing. Sometimes they go to vacations, they do not apply, they will apply a month later, and so on. So I do believe that it is too heterogeneous to give just one statement about adherence.
Thank you, André. What about Laura? Laura, what about the PsA?
Yeah, so I think I would agree with Alice. I think it depends a lot what the medication is, how nice it is, how easy it is to take, what side effects you get, how much better it makes you, how much you need to be on it all the time. Obviously, we have patients who are stable, who take their biologics less frequently, and that's fine. We have lots of protocols for tapering biologics, so that people take them slightly less frequently or in a lower dose, but enough that will control their disease, and so that's fine. I think we also need to be aware that there are things we can do to make this better. So there's some really nice work, particularly led from the team in Manchester in the UK, looking at adherence with methotrexate in their patients in rheumatology. They did a lot in terms of reminders, consistency within the group. They looked before they put in all of these reminders and support for the patients at self-reported adherence on an anonymous questionnaire. So they just left it in the outpatient waiting room. And when they re-audited later, things had improved quite a lot. And they managed to show that with methotrexate blood levels as well. So an objective measure. So I think it's also that we have work to do to support our patients, to make sure they know how to take the medications, when to take the medications. Methotrexate, despite all of our best efforts, gets confused quite a lot. People take it 1 day a week, but only one tablet, or they take one tablet every day, or one tablet 6 days a week, despite written information to explain how to take it. So it is quite complicated for some patients, and I think a bit more support can help.
Thank you very much. So these are the reason for lower level of adherence. Psychological distress and low patient satisfaction with care or therapy were associated with lower level of adherence. Rate of adherence to topical medication were low, with 39 and 73% of patients with psoriasis not using a medication as prescribed, and revealed that the effectiveness and the characteristic of the treatment were the main contributors for increasing adherence to psoriasis medication. Prescribing therapy not in line with patient preferences, and also patient-physician relationship or patient motivation. The next. Are there other reasons why patients are not adhering to the treatment, in your opinion? A slide back so we can have the possible. Okay, thank you. I just to put the focus on the relationship, the importance of the patient-physician relationship in terms of motivation, in terms of trust. I trust your prescription, so I do your prescription. I don't trust in you, I don't follow you. What do you think? Other comments? I don't know. We want to start from André? What do you think?
Yeah, I completely agree, Paolo. I think that having a great patient-physician relationship, it's the basis of a good adherence. Another thing that we say that is if you just plan ahead what you are going to do if the patient fails what you are giving them. So our goal is that we are not if for some time you use this thing and it doesn't work, we are going to do something else, and you just plan ahead. It's usually better for a patient to understand that if that thing fails, you have some other thing to do, and in the patient's head and in the physician's head, it's a set plan. It tends to get people better to adhere better to the treatment because they have something objective to follow.
Thank you very much. Uli, please.
Yeah, this is an interesting question. Some years ago, we published a study that we have performed in Germany with Divobet gel, so a gold standard topical at that time. And the groups of the patients were divided into two. One got just a very short information about how to use the drug, so once daily, and then as an improvement will be seen, full stop. The other part, the other group got a much more sophisticated information, and this was delivered first by the treating physician. Thereafter, there was an additional information delivered by the study nurse, and then the two groups were compared regarding efficacy. And in this increased, let's say, information group, efficacy was also better as compared to the short information group. And then the patients were asked what was the best feature of the encounter in this specialized information group. And they ranked number one, the talk with the doctor, number two, the talk with the nurse, number three, written information. So I think it is not to our surprise that this motivation aspect that you've listed in your last line is best if there is a time for the doctor to talk with the patient. And that's, I think, not only for topical treatment, as we have proven this in the study, but I think it's for all treatments.
Thank you very much, Uli, for the comments, also for remembering me the T-top study. I did it together with other international centers several years ago, Uli. Time is passing, Uli. Okay, this is the point. What to do to improve adherence? Let's say to topical, but let's say to any treatments. So we have already discussed the improved communication, and the beautiful Uli reported that this example from literature. Provide written instruction, simplify treatment with easy to use and pleasant products that were preferably applied once daily. And then this was a study from Louis Puig. The panelists agreed that treatment satisfaction increased adherence and tend to improve with the quality of life of patients with psoriasis, highlighting the relationship between treatment satisfaction and treatment adherence. So I would like to ask very briefly to the other that want to intervene. I don't know, Alice, André, Laura, if you think that other issues are critically relevant to be improved for increasing adherence.
Are we talking about just to topical or to anything?
Anything, any treatment.
So I agree that I think what I do with my patients is that and it really does depend on the patient. Some patients
Right.
just want, doc, tell me what to do. All right, gets a different attitude than a patient who comes with, you know, the latest New England Journal article and asking me, you know, whether that's a treatment for them. They get a different kind of treatment, but the people in the middle, I kind of emphasize it's a collaboration. I ask them, let's say for psoriasis only, I'll ask them, what's the most important thing for you? For instance, choosing between an IL-17 blocker and a 23 blocker, assuming everything being equal, I ask them, what's more important for you, that you get clear faster or there are fewer injections? I mean, getting the patient to be the collaborator rather than me telling them what to do, I think does help. And I do think it's important. I do with most of my patients is I kind of figure out what's important to them in their life. I get to know them a little bit, and I ask them about it each time. And that gets it. They know that I care about them as an individual, and I think that does help. I mean, I think you hear constantly from all of these things. It's a trust between the patient and the doctor, and that does take time. And there's no way getting around it. You can't farm it out to somebody else. That trust is between you and the patient. For psoriatic arthritis, we have not hit the same level of efficacy that we have in pure psoriasis. So there, you know, you're really, again, asking the patient about what things in their life they like to do and whether they can do it or not. And, you know, and things like that, and about their pain level. It's much more patient-reported outcome than, you know, I mean, because the same joint that can kind of look the same, but one hurts more than the other. But I do think it is about some real active collaboration, trust, and friendship between the doctor and the patient. And that goes a long way. And also goes a long way when something goes wrong. They forgive you more easily.
Thank you, Alice, for this insight. We are human beings. And so the importance of the relationship is crucially.